Good morning.
Good morning. How are you?
I'm doing well. About yourself, doctor?
Good, good, good. Well, nice meeting you, Marisa.
Oh, you as well in person somewhat.
Yeah, yeah, yeah. Well, albeit on Zoom, but at least we see each other.
Absolutely. Absolutely.
Well, we're very happy to be with you and delighted that we're doing this. And thank you for the invitation.
Oh, well, thank you so much for attending. After seeing everything that you've done and what you've participated in, advocating for science, and I'm excited to have you here. So thank you.
Thank you. Thank you.
Okay, we have a few more minutes before we get started.
Yeah, I logged in a little bit early just to make sure that the audio works and everything. Do you want me
Awesome.
to just maybe try sharing my slides just to make sure it works?
Yeah, absolutely. I'm going to make sure I've got the settings on here. So one
Okay.
panelist at a time, host and panel. Okay, you should be good now.
Okay, let me share my slides.
Okie dokie. Yep, I can
Do you
see you.
see that? Perfect, perfect. Okay, I'm gonna stop sharing then. Okay.
Okie
I just
dokie.
want to try it. It's always helpful to make sure everything works well before we start.
Yeah, definitely. Absolutely.
I'm trying to figure out how to get myself out of the presenter area because it just automatically logged me in as Disability Network.
Let me. I think this is how I do it. I'm going to see if this. If it kicks you out, Brad, I didn't mean to.
Okay.
I'm telling you ahead of time. That's not my intention. Let me see if that does it. No, it looks like it's calling you a panelist, or no, it did change it to panelist. That's what happened. Okay.
Hi, Krista.
Hi, good to meet you.
Good morning.
Nice meeting you too.
So nice to see you.
Thank you. Nice to see you too. Thank you.
Hi, Marisa. How are you?
Oh, doing well. About yourself?
Hanging in there.
Yeah. Oh, gotcha.
Let me see if I can manually come in through like my personal Zoom account and just
Okay.
enter the meeting data. That way I don't
Okay.
complicate this.
Sounds
Hi guys,
good.
thanks for being here.
So just so you know, this is my first doing slides online.
Okay.
I've done it in person. So if you can just keep me on track, I have notes because I do better with talking points. But if I'm running over or I'm talking too fast, please just flag me because I want the interpreter to be able to interpret if I'm talking too fast. It's really hard for them, to interpret what we're saying.
Oh yeah, absolutely. And Krista, do you want to control your own or want me to control it? Your slides?
Oh, if you could control it, that would
Yeah,
be
I
one
can do
less
that.
step. So I'll just
Yeah.
tell you next slide, please.
Okay.
That would be great. Thank you.
Absolutely. Yeah, no problem. Absolutely.
I think that's all set up to work, but I'm not sure.
And I do have it. I pulled them up. I have them with me just in case, like on here, so I could pull them
Okay.
and be ready. Yeah. And I'm going to give it a few extra minutes or actually another minute, waiting. The translator's not on just yet.
Is it nice and cool where you are in Michigan? Because it's nice in Vermont today.
Too cool. 47 degrees overnight.
Oh, oh
Oh,
wow.
wow. That's cold.
That's quick.
That's fall.
Yes, it is. It is.
Oh yeah, I'm not. August is our hottest month. I don't know what happened.
Yeah.
Global warming, maybe? I don't know, but
Oh no, that's definitely not August. Yeah.
yeah,
And you're by the lake. Does the lake often do that? Make it cooler?
not to that degree.
Right.
Yeah, not. I mean, there's definitely a difference, but yeah, not quite like this. This is extreme. This is extreme weather as far as I'm concerned. Okay. I'm not seeing her yet. Let me see. I'm just gonna give her an extra minute, guys.
Sure.
Get
No
on.
problem. Take your time.
Okay,
No.
just want to make sure.
I was so happy to hear, Dr. Ali, that you could make it to this. I know that you must be extremely busy. I mean, your name is everywhere and all the work you've been doing for people with long COVID. Amazing.
Well, thank you. Thank you. It's busy, but this is really important to me. This is really
Yeah.
important to me. Yeah, and yeah. And I'm really delighted to do this. And thank you for the invitation again, Marisa. Thank you.
Oh, I can't thank you enough. I'm just,
You know, it's important to do the science, but it's also important to communicate it, and important also to talk to people and ask, you know, address questions and all. That's very, very important. And we can do papers, we can do science, or I can write them all day long. But it's very important to connect with the people who are actually, you know, impacted by these illnesses.
oh, and COVID, this is the one unique thing that, you know, those of us have been in infectious disease or in research or kind of that usually are in the backdrop. With having this as a global event, people are getting, I would say, a crash course on what research looks like that they may have never even been part of, to know how things are constantly changing. And that's a norm. That's typical. You know, so I think it's really important to get this out so people can see this is a normal pace. This is how, actually, I would even say it's faster than usual, but, you know, in terms of that things are constantly changing, that's a good sign. Yeah. So, but if you're not familiar, it's shocking, you know, to see that. So
It's just been really nice, just, you know, your original ask was, let's start talking about long COVID. And, you know, yesterday, all the presenters also who said yes to talking about long COVID, you know, Dr. Koroshetz and Dr. Sequelae. I mean, that's just you asking, and people are willing to talk about it. For me, that's not what I've been seeing. So it's just been really nice that that's actually happening.
thank you, Kristen. I think so. We got to have these environments, you know, whether virtual or in person, that really encourage that dialogue. I think dialogue is so important on this. So that's how we break down stigma. That's how we encourage people to speak up for themselves or ask questions. And then on top of that, the cool part, how I always hope someone hears this and they're like, you know what? I think I want to go into research, or I think I want to go into that. And you never know what you could spark that direction to. So the more we talk about it, the better, you know, in any direction. You know, get rid of fear, get rid of concern, and replace it with knowledge. And if I do have questions, I know where to go to. So yeah, definitely. I'm going to go ahead and get started. I don't see her on here yet. So she just may be running a little bit late, but she can catch up with, you know, with providing that. So we'll go ahead and get started. Okay, let me get out of this view here. So good morning, everybody, and welcome to the second day of Let's Talk Long COVID webinar series, brought to you by Disability Network West Michigan. My name is Marisa Salisbury, and I will be your moderator. Before we get started, a few housekeeping tidbits. Each day the webinar series is recorded, which you would have heard that message as soon as you logged in to say that the webinar is being recorded. And although everyone is muted, time permitting, you're encouraged to ask questions through the Q&A section at the bottom of the screen. If you do not want captions turned on, right now the captions are currently showing. So if you do not want them on, all you have to do is go to the bottom of your screen and hit captions to turn them off. After the webinar series has concluded, a list of resources and references will be emailed to you. So as a CIL, or Center for Independent Living, one of the services we provide are education opportunities. We are excited to offer this webinar series, bringing experts to the top of their fields in research, clinical sciences, Veterans Affairs, and advocacy into your offices and homes to provide up-to-date information about post-COVID condition, or PCC, also known as long COVID. The information provided during this two-day virtual event will be geared towards both professionals in healthcare and public health, as well as community members that do not currently work in healthcare or public health. As a public health professional that has been part of COVID from the beginning in contact tracing, and is currently looking at the effects of COVID in communities to help people make emergency plans, I am very excited at the leaders in science and advocacy that have spoken during this webinar series over the past 2 days. And I cannot say that enough. The willingness for professionals to be part of this, to get information out, I'm elated. So, and I'm excited to bring this out to you, to our communities. Today, we're going to see presentations from Dr. Zayed Al-Ali and Krista Coombs. Their presentations will talk about the effects of long COVID on veterans, how we can advocate for ourselves and others, and how or why long COVID may be difficult for some to understand. I would like to now present our first speaker, Dr. Zayed Al-Ali. Dr. Al-Ali is a physician scientist. He directs the Clinical Epidemiology Center and serves as the Chief of Research and Development Service at the VA St. Louis Healthcare System. He is a senior clinical epidemiologist at Washington University in St. Louis. He has several research interests, including pharmacoepidemiology, environmental epidemiology, global health, and most recently, short and long-term effects of COVID-19 on health outcomes. He led work which provided systematic characterization of the post-acute sequelae of SARS-CoV-2 infection, also called long COVID, and subsequently characterization of the increased risk of cardiovascular disease, neurologic disorders, diabetes, dyslipidemia, kidney disease, and gastrointestinal disorders following SARS-CoV-2 infection. His laboratory was the first to produce evidence characterizing the effects of vaccines on long COVID, the health consequences of repeated infections with SARS-CoV-2, and the effects of antivirals on short-term and long-term outcomes of SARS-CoV-2 infection. Dr. Al-Ali led seminal work in environmental epidemiology and characterizing the health effects of air pollution on obesity, diabetes, kidney disease, and early mortality. His lab produced significant work in pharmacoepidemiology, particularly in comparative effectiveness and risks of community-prescribed medications. Dr. Al-Ali co-chaired the U.S. Biden-Harris administration committee that developed the National Research Action Plan for Long COVID. He serves on the U.S. Government Interagency Long COVID Coordination Council. He currently serves on a consensus committee at the U.S. National Academy of Sciences, Engineering and Medicine, looking at the long-term health effects stemming from COVID-19 and their implications for the U.S. Social Security Administration. He is also a member of the White House Cancer Moonshot Task Force for Data and Innovation. He testified before the U.S. Senate as an expert witness on long COVID. Dr. Al-Ali was listed on Time 100 Health Times list of 100 individuals who most influence global health in 2024. Dr. Al-Ali's work is published in prestigious medical journals, including Nature, Science, Nature Medicine, the New England Journal of Medicine, the British Medical Journal, the Journal of the American Medical Association, the Lancet, and several others. According to Google Scholar, his work has been cited more than 100,000 times. His work is frequently featured in major national and international media outlets, including the Washington Post, New York Times, Wall Street Journal, NPR, BBC, CNN, and several others. Welcome, Dr. Al-Ali.
Well, thank you very much for having me, and really delighted to be with you. And really, again, it's an honor to be with you guys today. And thank you for the invitation. I'm gonna go ahead and share my slides, and then so what I'm going to talk today about is really a brief overview of what long COVID is from our vantage point, and hopefully we can have subsequently a Q&A with the audience to sort of address questions that they might have. So into the outlines for the talk, I'm going to talk initially about broad overview of long COVID, talk a little bit about reinfection. Does reinfection really matter? And how long is long COVID? And then talk about whether the risk of long COVID changed over the course of the pandemic, the effect of vaccines and antivirals, and offer some reflections on opportunities and challenges. So what is long COVID? In a very, very early phase of the pandemic, the condition did not even have a name at that point. We started receiving, calls and accounts by patients that they were getting COVID-19, but they were not fully recovering from it, that they got the initial infection, but then weeks later, they have this brain fog, they have this fast heart rate, they have this weakness, this fatigue, you know, and at that time, you know, the condition did not have its name, but we started sort of paying attention to these accounts by patients and asking ourselves, what is going on? You know, SARS-CoV-2 is supposed to be a respiratory virus. It doesn't affect, you know, doesn't do all these other things that people are talking about, that our patients were talking about. And it's supposed to be sort of self-confined, and it really, you know, affects people for, you know, a week or so, and then it all goes away, especially if you're young and healthy. So we started asking questions, and what is happening with these individuals, and did this analysis systematically to try to evaluate all the long-term health effects of COVID-19. What we found that it can affect the nervous system, it can affect the metabolic system in the sense that, you know, COVID-19 was resulting in people having hyperlipidemia or high cholesterol and diabetes. It was causing them GI upset. In some patients, it can result in constipation, some people diarrhea, abdominal cramps, all sort of stuff in the GI system. In some patients, there were skin problems or skin disorders, coagulation or clotting disorders. You know, if you heard somebody had long COVID talking about clots or microclots, that is real. We see it very clearly in patients, and we see it in the data. Cardiovascular conditions, you may have heard about POTS or other conditions, but it's really a broad gamut or a broad, you know, category of cardiovascular problems that can happen in long COVID. And also respiratory problems, you know, SARS, you know, initially starts with the lung, and in some individuals, you know, that those lung problems really never, you know, subside completely and go away. Kidney issues, musculoskeletal problems, and general problems like you know, fatigue and other things. So, and then very early on in the pandemic, we sort of zeroed in on things that we sort of call here sequelae of concern, things that are really, it's not just a mild thing. These are really fundamentally can alter people's lives, their ability to work, their life expectancy, their quality of life, et cetera, et cetera. And these include cardiovascular disorders, diabetes, kidney problems, neurologic problems, and gastrointestinal disorders. And we wanted to do a deeper dive on each one of them. This is one of our first paper looking at the, you know, the COVID horse, so to speak, or the long-term consequences or long-term cardiovascular outcomes of COVID-19. That's under the basket of long COVID. So to rewind a little bit to tell you that, you know, for the audience here, if you came to this talk thinking that long COVID is only brain fog and fatigue, it's that and many and much more. Long COVID can affect literally, you know, as I mentioned on the slide here, literally every body system, literally nearly every organ system. If you look at this body here, it's like, what is not affected? Almost everything is affected. So that is long COVID. Yes, in your neighbor or in your friends, you know, or loved one, they may have fatigue or post-exertional malaise or brain fog. But long COVID is not only that. You know, long COVID comes in different shapes and forms, and it literally has manifestations across nearly every organ system. It can touch nearly every organ system. So here we wanted to study the heart. It's like, okay, what are these people, you know, having? And what we found is that we found things from mini strokes, you know, like small strokes to large strokes to disorders of the rhythm of the heart, you know, meaning some people have either very fast heart rate or slow heart rate, inflammation of the heart in the form of myocarditis or pericarditis, sometimes, you know, heart attacks, you know, heart failure, and blood clotting. And it was very clear to us that, you know, even if you had a mild case of COVID-19 in 2020, this study actually dates to the era before the vaccination was, or vaccines were available. You know, even in mild cases, you know, COVID can lead to long-term health effects on the heart. And this is a paper sort of showing the effect on diabetes, you know, very clearly. You know, there is an increased risk of diabetes in people with COVID-19. That also falls under the umbrella of long COVID. This is also dyslipidemia or increased risk of high cholesterol. People are having high cholesterol. And we worry quite a bit about kidney outcomes in people with long COVID. This is a study, you know, evaluating the trajectory of what we call GFR. That's a marker of kidney function. And then if you look at this graph, you see all these like lines going down. So what does that really mean? You know, they're going down, and you know, the order of decline here is about 2 to 4 milliliter per minute. And you should ask me now, what does that really mean? What does 2 to 4 milliliter per minute decline in kidney function really mean? What it really means is that these people's kidneys aged about 4 years in the span of just one. So you can think or start thinking about sort of a, COVID and long COVID as almost a form of accelerated aging, that you may think you're 20 years old, you may think you're 30 years old, you may think you're 40 years old, but if you have long COVID, if you have these long-term health effects of SARS-CoV-2, your body is actually, you may think you're 30, but your body is maybe, functioning as if it's 34 or 35. You're literally, aged, several years in the span of just one. It's sort of a form of accelerated aging, and you're feeling fatigue, you're feeling slower, you're feeling foggy, all these manifestations. And here very clearly shows in the kidney and kidney markers, these kidneys were behaving as if they were like, in the span of just 1 year, they were behaving as if they aged 4 or more years. And then we looked at the brain. We wanted to sort of understand more deeply what's happening in the brain of in people with long COVID. And it's very, very clearly that there's a lot of brain inflammation that is, and people manifesting in all sorts of things. Again, it's not only brain fog. It's very common. Maybe friends and colleagues have brain fog, but it doesn't really stop there. Some people have headaches. Some people have seizure disorders. Some people have some sensory disorders. We've all sort of heard about that. Some people have other forms of inflammation in the brain that causes several sets of diseases. So it's what I want to leave you with the impression that it's really not just one thing. It's not really only brain fog. It's really a broad array of problems that causes several clinical manifestations, including headaches, seizures, et cetera, et cetera. And then, there are GI manifestation, gastrointestinal manifestations very, very clearly. People have irritable bowel syndrome or constipation or diarrhea and other forms of gastrointestinal problems. Now, does reinfection really matter? And the answer is, in our view, is yes. And in our data is very clearly, we see that the answer is yes, that it's not necessarily that the second infection is always worse than the first. Actually, many of the people that you'll see in your life had a second or third or fourth infection, maybe milder than the first. But the point here is that you could still get long COVID after a second infection. You could still get long COVID after a third infection or a fourth infection or a fifth infection. That every infection that we're having is an opportunity for you're trying your luck again at getting long COVID, so to speak, and you may have dodged or people may have dodged the bullet and did not get long COVID in the first infection or second infection or third, but they may then get it after the fourth infection. It's very, very clearly that's really what's happening here in the data. And then people say, how long is long COVID? This is really, do people really recover? Is long COVID sort of really a misnomer? It's not really long. It's, it goes away in like 6 months or 8 months. And the truth is that we followed people here for several years, in this study for 3 years. The truth is that some people were actually still manifesting with new onset problems 3 years after the infection. So what that really means, is that you may actually have forgotten that you had COVID 3 years ago, but COVID did not forget about you and is still wreaking havoc in your body. There are still people who are manifesting with even new onset problems 3 years after infection. Clearly, this is really not a short-term or intermediate-term disease. This is really a long-term disease, at least as far as we can see here in the data for 3 years outcome. Very, very clearly, this is a long-term disease. So what about prevention? Well, the best way to prevent long COVID is to prevent COVID in the first place, and that's really, really evident. But also vaccines work. Vaccines reduce the risk of long COVID. Do they eliminate the risk of long COVID? No, they do not. They don't completely eliminate and wipe out the risk of long COVID, but they do reduce the risk of long COVID. Antivirals in the form of Paxlovid and Molnupiravir and Lagevrio, in people who qualify for them, and that's not everyone. Not everyone will qualify for Paxlovid, but if you're over 80 years, over 50 years of age, or have a medical condition like diabetes or heart disease or kidney disease, you may qualify for Paxlovid. And people who qualify for Paxlovid, their risk of long COVID is less than people who don't get Paxlovid. So taking Paxlovid or taking antiviral in the acute phase of the infection actually reduces the risk of post-acute problems or reduces the risk of long COVID. And maybe now you'd be thinking, okay, well, like what causes all of that? Like why are we, why are we or our friends are having, long COVID and having brain fog and having fatigue or post-exertional malaise or POTS or other forms of long COVID? And the answer is that there are likely multiple mechanisms at play. One is viral persistence. So, the body is supposed to be able to clear and get rid of the virus completely, clean it out and get rid of it completely in a week or two after the initial infection. But in some individuals, it appears that they're not able to completely get rid of the virus, and the virus persists. That means it stays in body parts, and it triggers an ongoing inflammation in the brain and the gut and other places that leads to all those symptoms. If a friend or loved one is like, oh my God, I'm having all these cramps all the time, or I'm having this brain fog with the inflammation in the brain, that could be due to viral persistence. Number two is the immune system could be dysregulated in the sense that it could either have reacted too strongly, developing, sort of almost starting to attack self, or too weakly to the initial infection. There is this idea that the viral infection with SARS-CoV-2 or with COVID-19 can also induce microbiome dysbiosis or can disturb the bacteria that sort of live within us and on us, and that really maintains our health. And an infection with COVID-19 does not only hurt us, it hurts also the bacteria that's within us. And then when these bacteria or this microbiome doesn't fully recover after infection, that also leads to a state of disease. There is a microclot hypothesis, or the clotting hypothesis, the idea that there are microclots that form in all sort of capillaries and blood vessels, leading to deprivation of oxygen. So that because of these vessels get clogged, literally clogged. Think of it like a plumbing system gets clogged with these clots. So there's not enough perfusion or not enough blood flow to actually bring oxygen to the brain, so the brain can remember things. And this is why people can have brain fog and other problems. And obviously, neural inflammation or inflammation is one of the leading hypotheses, and mitochondrial dysfunction. These energy bunnies that are in every human cell, you can think of them as batteries for our human cells. When these batteries are dead or dysfunctional, guess what? We're not going to feel very good. We're going to feel tired. We're going to feel exhausted. We're not going to be able to recuperate. We're not going to sleep very well. So a lot of the manifestations of long COVID could also be explained by these mitochondrial dysfunction, these energy bunnies that could be present that could be dysfunctional in long COVID, leading to a state of disease. And now you should be asking me, like, so what's the cost of all of this? So we actually recently estimated the cost of long COVID, and it's not really a small problem. It is a big problem. We estimated it affects or costs the global economy $1 trillion per year. That's a huge number. That's about 1% of the global economic output. That's sort of that's really humongous in terms of a worldwide economy. And we estimate there are about 400 million people with long COVID in the world, including at least 22 million people in the United States, in our country. So 400 million people in the world, with an economic price tag of $1 trillion. This is not a small problem. This is absolutely not a small problem at all. And then, we think of it always. We sort of think like, okay, we have problem. We have this long COVID is a huge problem, and we need to solve it. And how do we solve it? We really need to double down on doing more research in biological mechanisms, diagnostics, so we can actually discover ways to really more formally diagnose long COVID. Trials to test therapeutics for long COVID, because if you've had a loved one who's affected by long COVID, none of this talk really matters. What they really need yesterday is treatment that works, that makes them feel better. That's what they really need. And this is what we need to keep working very, very hard to accelerate the search for therapeutics that works in these individuals to help them feel better and regain their health. We obviously need to understand better the epidemiology and clinical course of long COVID. We need to deliver better care for people with long COVID, care delivery and health system research to figure out like how to deliver the most optimal care for long COVID. You may have heard stories that You know, people went to the doctor and they told them it's all in your head, or it's a nothing burger, or I don't know what to do with you. I don't know anything about long COVID, so I'm not going to do anything about it. So we need to do better. So that's really why this is here, care delivery and health system research, to figure out like how to deliver better care to these individuals. We need to gain a better and a deeper and a more even detailed and nuanced understanding of the economic impact of long COVID and societal impact. In terms of policy, what we really need our policymakers, and if you get their ears, this is what you want to send them. That we want policies to help us prevent further, you know, more cases of long COVID. We need to support the people who are already impacted with long COVID. There are, you know, again, 400 million around the world, that at least 22 million among us here in the United States, and these people need support. And we cannot really function well as a society and pretend that we're, you know, doing well without really supporting the impacted people with long COVID. We certainly need policies that facilitate access, quality, and equity of care. We need to train healthcare providers. I'm really sort of really sick and tired of you know, hearing that healthcare professionals in 2024 don't know enough about long COVID and not able to address, you know, long COVID in their patients. We need to do a better job educating and training them and empowering them with the knowledge and the tools to address the care needs of people impacted with long COVID. Definitely need to be a lot of public health communication, you know, we definitely need to support a coordinated interdisciplinary approach. We need consensus on definitions and clinical endpoints for long COVID. We need global coordination. This is not a US problem. This is not a UK problem. This is not an Australian problem. This is not an EU problem. It is a global problem. It is a worldwide problem. And we need to solve it together. We really need sort of a collaboration, coordination from across the globe to sort of help us tackle this problem and solve it. I think we need to develop professional societies for long COVID. And if we learn one thing from this pandemic, is that pandemics disable people. Pandemics disable people. You know, if we've learned one thing from this pandemic, is pandemics disable people. And if we don't learn this lesson, and with an eye to prepare for the next pandemic and hopefully reduce the probability of people being disabled by the next pandemic, we would have failed miserably. So it's very, very important to learn from the lessons of this pandemic, because we're gonna be hit with other pandemics in the future. Guess they're going to happen. We just don't know if this is gonna be 10 years from now, 20 years from now, or 50 years from now. But it's kind of like an earthquake. They're going to happen. They're going to happen. They're going to happen. And we need to be prepared for those. And we need to definitely, very importantly, learn as much as we can from the current pandemic to help us optimize preparedness for the next one. So in summary, sort of, I hope that they gave you a sense that long COVID is not just brain fog and fatigue. You know, it's really a whole lot more than that. It can affect nearly every organ system. And the risks are increased by reinfection and reduced by vaccination and antivirals. The human and economic toll of long COVID is quite significant. This is not a small problem by any means. And we really need to focus on developing coordinated policy and research response strategy. We cannot just like ignore this problem. We cannot literally ignore this elephant in the room. It demands an urgent response and a coordinated policy and research response strategy. So thanks to my team here, who have always been very helpful in supporting me and supporting us in generating most of this data. And I am always available on X, on Twitter, what was Twitter before, X, at ZALALY, and really would be delighted now to do a Q&A.
Thank you so much, Doctor, for that fantastic information. I've got a whole list of notes here that I was taking as you were speaking. So I mean, that $1 trillion price tag is mind-blowing, is absolutely mind-blowing. So I have a question for you. We know in public health that one of the ways we are able to get someone's attention, you know, organizations, voters, whomever, you know, to get attention and say, hey, this disease is a big deal. We attach things like DALYs to say, this is what it costs us for this disease over this period of time, loss of work, health insurance costs, all these figures that are put into those accounts. why are we not hearing more, do you think, about like having $1 trillion price tag? Seems like that would really wake up people. I think that even if it's the first time, it may at least get your toes wet too. This is a bigger problem than I think some realize. Why are we not hearing more about it in that direction?
I think because the field is still nascent, like I tell people, like if long COVID was a kid, it would still be in kindergarten. So we're still in, it's still a new disease. Yes, we have made a lot of progress on understanding long COVID in the past several years, but I think we're just beginning to sort of understand or unearth or really peel those layers of the onion and figure out like, oh my God, this is actually costing a lot in economic losses, because people are, guess what? People are not able, like many people are actually disabled. They're not able to go to work, or even if they go to work, their productivity is impaired. There is cost to the healthcare system. Their caregivers, people forget like, oh, that's like the patient. Like there are 22 million people with long COVID in the US, but everyone has 2 or 3 other caregivers who are also impacted, right? So maybe not everybody, there are the caregivers, sort of these individuals are our family, our friends, our colleagues, right? So they live in ecosystem, they live in our society, in our midst, and so I think we're beginning to tally up to sort of really understand, how long COVID is affecting our society, is affecting our economy, our economic productivity, labor supply in terms of like hours work, et cetera, et cetera. And those studies are actually coming out. There was a study that was published several days ago from Australia, showing really a significant economic toll of to the Australian economy, but by the individual, by the Australians impacted with long COVID, right? So very, very important data. But this is emerging, and so there are going to be more and more of it. Our group and others, there are going to be more and more of it. But I think that in the very first 2 years of the pandemic, would be very hard to do these things, because we were like at that point we're trying to wrap our head around what is long COVID, what is this new thing. People are telling us about brain fog and fatigue and post-exertional malaise and all these different things, but we're trying to wrap our head around what this entity is. And I think there are going to be more and more studies on the economic consequences of long COVID, and also the societal impact. This is really, it strains not only individual, lives and well-beings, but also strained marriages. We have people, say, oh, like I lost my marriage because I couldn't. Upended friendships, relationships, work relationships, collaborations. So it has a significant strain on our society and also on our economy.
So you mentioned in there about how it can be difficult for people to get information or have a doctor, oversee care, that occasionally this is something that people encounter. So I have 2 questions for you with that. One, where can health professionals turn to get more information for educational purposes? And 2, as a patient, how do you, what is the best way to communicate? If you feel like you're, for any reason that it's not going beyond that visit, that's not going to either sent to, like yesterday we heard from U of M long COVID clinic. So there's not a referral going there. There isn't any talk about bringing someone else into the team, if the doctor is not familiar. So for those 2 groups of people, what do you recommend?
So first of all, healthcare professionals, there are a lot of resources out there. In 2024, there's really no excuse that if you're a primary care provider or your physician doesn't really know about long COVID, I'm sorry, there's no excuse for that. There's absolutely no excuse for that. There's a lot of resources out there. For example, and I don't want to sort of advertise one over others, but there's really a lot. Like one just as an example, and I'm not endorsing them, but they, in my view, they do a good job. But the AAPMNR, the American Association of Physical Medicine and Rehab, they have guidelines for how to manage POTS and how to manage dysautonomia and how to manage post-exertional malaise and brain fog or cognitive problems after long COVID. So the information is out there. There's no excuse in 2024 to say, I've never heard of this, or I don't know anything about this, and I'm not gonna address your problem. I'm gonna just leave you to deal with it on your own. There's really no excuse. But there is a responsibility, so it's not only the individual responsibility of the physicians to really learn. There is a responsibility for professional organizations to provide that training and then to also incorporate it in the continuing medical education credits. And what do I mean by that? I mean, like, the American College of Physicians has an obligation in its meetings. They have a national meeting every year to have workshops on long COVID. So its workforce, so the 50,000 or so attendees that attend these large conferences, so are trained on long COVID. So American Heart Association, the American Diabetes Association, all of these professional societies have an obligation to make sure that their physicians that come to their meetings are also trained on long COVID. Now, on the patient side, if you're, the way we hear from patients is that if they join, there's a lot of online places where people join and find community, so that helps exchanging information with other people who may be experiencing similar problems, et cetera, et cetera. There's also a lot of resources online for patients, but always beware that I don't want to place the burden on the patient to solve the problem. And a lot of times when our physicians fail us, we say, okay, then the patient has to find their own cure, their own treatment, or the information to teach the physician. It's not supposed to be like that. And I know we're compensating for our medical workforce that is not really stepping up to the plate and doing what it's supposed to do. So we, like the patient, compensating, they do all these, they actually go to the AAPMR and download the brain file, say, here you go, they actually give it to the physician. They're trying to teach the physician. I applaud that, but it should not be we should not burden the patients who are already suffering. They already have brain fog, they already have fatigue, they already have PM, they're already enormously burdened by long COVID and trying to deal with it. Add on top of that the burden of actually trying to teach their physician. Like, it's not supposed to be like that. Like, it's not supposed to be like that. That's not how it's supposed to be. So I'm always, cautious about like saying, like, giving all that responsibility to patients. It's not their responsibility. Their responsibility is to take care of themselves, and the doctor's responsibility is to figure out how to really, and obviously ultimately when decisions are need to be made, it's like the shared decision making. So it's not that, but it's very important not to sort of overburden patients with all that responsibility and say, like, it's your problem, you have to figure it out. No, we need, as a professionals who are dealing with healthcare in the United States, that we need to train our people, the cadre of professionals, to be able to recognize and treat long COVID.
Awesome, thank you. And we do have a question on here. This is from Brad. I think there's a lot of misinformation about long COVID, and people are trying to attribute long COVID to negative impacts of mRNA vaccines, or saying that these are other separate health conditions. So he says, how do you respond to people who say these things? I also think some of this is just a general lack of competence around science and healthcare. Is there any work being done to put out plain language materials, media that talks about this stuff in language that the average person can understand? So we got a two-part question there.
So yeah, this is so first of all, the vaccines, long COVID existed way before the vaccine. Long COVID, like the first cases of long COVID emerged in March and April 2020. The first op-ed piece that sort of at that time it did not even have a name, but Fiona Lowenstein had an op-ed piece in New York Times talking about her story, back in April of 2020. There was no vaccine then. There was no mRNA vaccine then. The first wave of patients that hit the clinic, with long COVID is way before a vaccine was even available here, right? So that's really, it's a, again, nobody says that vaccines have no side effects. I tell my patients, even water has side effects. If you drink too much water, you'll get water intoxication. There's no medicine in the world. No medicine in the world has zero side effects. So we definitely need to acknowledge that vaccines, in very rare instances can cause side effects, right? So that any medicine in the world has side effects, even water, right? So we need to acknowledge that reality, but to sort of attribute long COVID to vaccine is really that does not align with reality. And then, the second component, and I think that is and this is what, in our review recently, we sort of called for better public health communication, precisely because as a person who asked the question, is he has, or she has, or they have their finger on it exactly, that we don't really talk about it enough, and we don't talk about it also in language that really empowers people to have responses to questions like that. And it needs to be, and that public health communication needs certainly to be beefed up. So they definitely have their finger on the pulse, and you know, that needs to happen. That's definitely a major gap.
Awesome. I wanted to make sure. Awesome. Thank you so much, Doctor. I really appreciate the time. And like I said, I actually have notes on my own that I'm sitting here that that I took while watching your presentation. So I cannot thank you enough for being here with us. And then I will be emailing out to participants too, the information that you provided. It'll go to everybody at the end of the week. Do you want any parting words?
Well, thank you very much again for having me, and please, you know, stay in touch, and you know, we're definitely committed to long COVID and want to make sure that we're doing our best to move the ball forward on long COVID, both in research and also in advocacy, to make sure that people are aware of long COVID, and then the government and other stakeholders are doing something about it, because that's very, very important. For the people who are watching, if this is their impact, if their family member is impacted, they actually need solutions. They don't need talk. Talk is easy and it's cheap, but that doesn't really help anyone. It really does not help anyone. What really helps anyone is actually action that really results in treatment that help people. So we need to keep pushing for that. Very, very thankful for hosting me today, and thank you very much.
Well, thank you so much, Doctor. I really appreciate it, and thank you.
Thank you, everyone. Bye.
Okay, so we're now on. We've heard for the last 2 days, we've heard from different people, different professionals, researchers, innovators, talking about what is COVID, what is long COVID, you know, what is that post-COVID condition. But now we're going to hear from Krista about what are we do with it? What's the action part? And like how Dr. Ali just commented, his last words were, now is the action part, right? So now we're moving into, let's talk about what we need to do. Let's talk about our next step. So welcome, Krista. Krista Coombs works to advance long COVID advocacy through her roles as a patient advocate, peer counselor, caregiver, and constituent voice. Krista and her 2 daughters fell ill early in the pandemic, prompting her to begin advocating as she encountered the numerous gaps and challenges in our healthcare system, particularly in rural areas and pediatric care. She now works part-time as a long COVID advocate at the Vermont Center for Independent Living, or VCIL, and as a director of policy and programs with the COVID-19 Long Haulers Advocacy Project, or C19 Lab, where she helps people with long COVID and pushes for greater support services and recognition. Additionally, Krista serves as a caregiver representative in the NIH Recover Initiative, focusing on pediatrics and pregnancy. Welcome, Krista.
Thank you so much for having me. And thank you for helping me with my slides. We're likely going to go over, so I apologize.
Give me just a second. It's delaying coming up. I'm sorry. Sorry about that.
That's all right.
A little bit of a delay here.
Sure. So thank you
Technology is wonderful.
Yeah, so thanks for including the patient and caregiver voice in these webinars. We need to hear more from people with long COVID about our experiences. This first beginning slide that we're going to see here has some quotes on it that I wanted to kind of set up the rest of the presentation.
There we go. Were you at the beginning?
No, that's the end.
Oh, I'm sorry.
That's okay.
Sorry about that.
I know it's hard to organize all this at the same time.
There we go. I had it. There we go. Sorry about that, Krista.
No problem. So Senator Sanders, I'm from Vermont, so he is my state senator. And he's been championing long COVID since January when he held a Senate hearing. He recently also introduced a long COVID research and education moonshot bill for $1 billion each year for the next 10 years for long COVID. This would be able to fast track therapeutics, hopefully educate medical professionals and increase social services, all that is greatly needed. The second quote is from the Nature paper that Dr. Ali actually was co-wrote from March 2024. As we are in a huge wave of a new variant of COVID, I know that there's going to be more long haulers joining us. So I thought it was important to kind of talk about how the world has moved on when some of us can't. This has all become very charged and controversial somehow, and many of us have been kept from society and getting the care and support that we need. We're not talking enough about COVID and long COVID and what it looks like right now and what it looks like for our future. You can go to the next slide, please. This next slide is kind of more about me, just kind of moving in my life from being a practitioner to an advocate. So I started my advocacy work in 2020 after realizing what was happening with long COVID. I had spent many months trying to figure out so much because it wasn't just me that was struck down. We were all struck down at the same time. At that time, my two daughters were 10 and 13. So our house went from a busy, exciting place to one of us being in our beds all the time with a lot of symptoms and the inability to stand for long and sometimes not at all. I recognize then that we weren't the same since this infection that we had, but I didn't know until 6 months later that others were experiencing something similar too. I kept believing that it would go away. My daughters and I often didn't get sick that much, and we had been feeling actually quite well at that time, and we were doing things like downhill skiing and rowing crew. We also sometimes in the past had experienced other sicknesses that last and lingered longer than usual for other people. But this time it was really different. It was more like we kept feeling better and then we were continually struck down over and over again. So we kept going through periods of being well and then periods of not being well at all. And then it kind of continued until it just became more of a constant thing. I struggled to stand for long as it would bring on a lot of symptoms, and my vision actually changed really suddenly. And it felt like my body was injected with this constant new tension. It was very confusing and uncertain. And this all started at the beginning of the pandemic too, when it was also very confusing. After learning about long COVID from Ed Yong's Atlantic article in August of 2020, I joined peer long COVID support groups, and I started hearing about so many other experiences and started my advocacy work. My oldest daughter is now 17, who has improved dramatically, which took about 2.5 years. My youngest is now 14, who continues to not be able to do very much, and she has to rest a lot. I also continue to be sick with many new diagnoses and conditions that keep coming as the years go by since my initial COVID infections and also since reinfection. In my current long advocacy roles, which Marisa told you about, I work at the Vermont Center for Independent Living, where I run a peer support group weekly. I also work within the Vermont State Congressional, trying to get things moving here too within the public health system, as well as with Senator Sanders and Becca Balint. I also work with C19 LAP. I've been working there since 2020 when they started. At first, I was leading the Vermont state chapter, and now I'm the director of policy and programs. C19 LAP has state chapters and territories, as well as community-specific chapters on Facebook. I also with NIH Recover, which I started in 2021, and I continue to be on multiple committees like pregnancy and publications. So my past work experience was as a traditional Chinese medicine acupuncturist, where I worked a lot with people with chronic complex conditions such as chronic Lyme and autoimmune disease. I became unable to practice due to long COVID after many attempts to go back to work. Next slide, please. So this has been interesting to me to try to figure out how do we count this? There's so many numbers out there about how many people have long COVID or COVID. So I kind of decided to do a slide on it today. So about prevalence, throughout the pandemic, and especially since the public health emergency ended in April 2023, I've been worried that since we aren't counting COVID correctly, then we aren't going to be able to count long COVID. I've been following this closely, and with these prevalence numbers, we are not looking at a rare disease at all. And even if a patient improves after 6 to 8 months of having long COVID symptoms, this is very disruptive and impactful as well. But many also remain significantly impacted for years, and some are worsening with more new conditions as the years with long COVID go by and reinfections occur. Long COVID disproportionately affects older adults and marginalized communities who are often most vulnerable to the severe outcomes of the disease due to lack of access to healthcare and other social determinants of health. This makes it very essential to focus on these populations when we discuss long COVID, as they face additional challenges in diagnosis, treatment, and recovery. Looking next at the code, UO 9.9, which is used now to identify post-COVID conditions. Most doctors are not recognizing that it's them who need to be adequately counting people with long COVID in medical records. So this isn't happening as much as it should, which means that we're not having good data saying how many people have long COVID in our country. Many healthcare providers are not fully aware or trained in recognizing the symptoms of long COVID, and they also think they're not the ones to diagnose it. So we're often kind of kicked like a can down the road if we're even able to go to a specialist. So this leads to underdiagnosis or misdiagnosis of the condition. Some patients also don't seek medical help for their symptoms because it's attributed to aging, stress, or other factors rather than recognizing them as long COVID. There's still a lot of stigma and skepticism around long COVID, both among the general public and within the medical community. And so when I was kind of trying to understand Michigan and what's happening in your state, I read about the Michigan C19 recovery surveillance study, which has been going on for many years now and still continuing. And one of the key findings from the latest data is that long COVID symptoms are more prevalent in certain regions, particularly in rural areas of Michigan compared to urban centers. The study also highlighted ongoing disparities in access to healthcare with specific challenges by racial and ethnic minorities, rural populations, and low-income communities. These findings are similar across the US. Next slide, please. I'm gonna go a little bit faster on these next two slides. So this one I just took from a recent publication by the NIH. The knowledge that routine blood tests are not a diagnostic tool for long COVID has been talked about for a while now, but this was just released and kind of is making a little bit of a splash for those of us who follow along this closely. And the second one, about 400 million people worldwide have had long COVID, researchers say. These estimates are based on a percentage of the global population that has been infected with COVID-19 and the proportion of those who develop long COVID, typically ranging between 10 to 30% when those statistics come from the CDC and the WHO. And this is actually from the Nature article that Dr. Alley wrote recently or co-wrote. Next slide, please. So the CDC's annual update reveals higher long COVID rates among people with disabilities. This is the first year that the agency has released long COVID data that they started collecting in 2022, finding that 11% of people with disabilities had long COVID symptoms, while only 7% of people without disabilities reported symptoms. The second quote shows researchers estimate 5.8 million children throughout the US have long COVID, which is through the it is through the Household Pulse Survey that was conducted by the CDC and the US Census Bureau, who also started collecting information in 2022. And this was published in February of 2024, this research. Next slide, please. The long COVID peers need help now. Talking about research is of course important, but what about direct support services and caring for people right now? Peer support groups are communities of individuals who come together to share experiences, offer mutual support, and provide practical advice related to living with long COVID or other similar chronic conditions. And the Centers for Independent Living are primarily focused on empowering people with disabilities to live independently, and they serve people of all ages. The Centers for Independent Living, or CILS, started in the 60s in post-polio conditions, and they are well suited to help long haulers with new and worsening disabilities. Next slide, please. As I lead a long COVID support group weekly in Vermont, and I've been in them since 2020, I find them to be really important, and they fill a lot of gaps to help people learn more about long COVID and its associated conditions. Joining with others who have long COVID or as a caregiver can help us feel understood and find new ways to get help. We often are telling people throughout Vermont, like what doctors actually are listening and who to go to. And that's invaluable information. It helps us not have to keep trying and using our energy in ways that make us actually feel a lot worse. Finding support. Being part of a peer group helps us learn how to ask for what we need by sharing our experiences with each other. And even if we don't have the support we need, that doesn't diminish our worth or our right to live as well as possible. We can learn to speak up and support each other, and being in groups help this. With community help, it's also easier to stand up for ourselves when we work together, knowing that we have to fight for what we need. People in support groups can share helpful advice for dealing with daily challenges caused by long COVID, as often we only are really the ones who understand. There are many peer support groups, like through C19 Lab, where people can join and share information regularly and feel stronger in our advocacy efforts together. Next slide, please. So what I have learned from long COVID, and this is partly through the support group and also through my own experience and just kind of surveying a lot of research and what everyone's been writing about and analyzing. So each wave of COVID brings more people who develop long COVID. We're starting to see people from January and February of 2024 coming into our groups now. Getting COVID again can make long COVID worse, or it can cause it for the first time. So reinfections are serious. Helpful tools like assistive technology devices, work or school adjustments, having your doctor's visits be online, and getting disability benefits are really helpful and important. Discussing your worst symptoms with your doctor is a medical tip, as it can help them understand your functioning. And even on the day that you go in, if you're feeling a little bit better, it's often helpful to kind of tell them what it's like on your worst days, so they can kind of understand more too. Reviewing your doctor's notes after appointments, a lot of people have found that helpful to see what's written, and consider a second opinion if you don't feel like your doctor is aware enough or willing to help you improve your quality of life. Obviously, this is a lot easier said than done, as it's hard to even just get one doctor, not let alone two. Resting and pacing can help manage the symptoms, such as from post-exertional malaise, which is a constant learning experience. Many people with long COVID have trouble with basic activities like eating, standing, sleeping, and thinking clearly. They also face challenges like job loss, housing issues, and loss of support from loved ones, while they have to constantly prove they deserve care and understanding. Next slide, please. How SILS can help people with long COVID. It seems again that we mostly want to talk about research and come up with cures and treatments, but what do we do in the meantime? We need to tap into and build into more resources and communities, like through the Centers for Independent Living, who understand disability, understand how to get accommodations within the workplace and education and in healthcare, and how to work with government agencies and help one protect their civil rights. On the side there, you can see this picture of Michigan. Currently, 14.7% of adults in Michigan have a disability, and that's about 1 in 4. SILS provide specific support based on what each person needs. That no two people are alike or have the same needs is nothing new, and SILS understand this. SILS advocate for better services and resources for all people with disabilities, and long COVID crosses all disability. Next slide, please. I was trying to think about a resource that could be useful and one that peers and caregivers can use to help them. This would be, so I chose the new NASM working definition of long COVID. This can be shared with medical providers, workplaces, and family members. So why this is important is the NASM report is highly influential. It's been along, the NASM committees have been along since the late 1800s. They're often adopted or referenced by federal agencies like Health and Human Services and the CDC to develop evidence-based policies and public health initiatives. Some other initiatives that NASM's been involved in have to do with Alzheimer's and dementia, the opioid epidemic, and HIV/AIDS. So understanding and adopting the definition is essential for patients and healthcare providers. So for patients, it provides a framework to validate experiences and seek appropriate care. For healthcare providers, it offers a guideline to improve diagnosis and treatment, ensuring that long COVID is not overlooked or misunderstood. As advocates, we can leverage the NASM definition to demand more comprehensive policies and services from government, healthcare providers, and employers to ensure that our needs are being met. So the definition helps get more understanding as well on coexisting conditions such as migraines, POTS, and something called myalgic encephalomyelitis. The definition also says that long COVID is an infection-associated chronic condition, which also elevates other ones, such as chronic Lyme, and again, ME/CFS or myalgic encephalomyelitis, which have been historically dismissed and understudied. The definition, which is the most part that I've been really excited about, is that it helps people with long COVID equitably. So under 4 here, it says it can affect children and adults regardless of health, disability, or socioeconomic status, age, sex, gender, sexual orientation, race, ethnicity, or geographic location. And having this embedded in the definition is really important and hasn't really been seen before. The definition also uses the term long COVID, which is a patient term. And it also shows how impaired and disabled one can become from long COVID, as it affects various organ systems and it severely impacts a person's ability to work and perform daily activities. Next slide, please. So this is my second to last slide. What more can be done about long COVID? So avoid getting long COVID. As spread is extremely high right now, it's important to use what tools are left. So those are masking, staying home when sick or there's an outbreak, and getting vaccinated as possible when this becomes available again in the next month or so. Early antivirals, we need more equitable Paxlovid prescribing. This has been a problem throughout the pandemic. Doctors keep telling patients that Paxlovid won't help or it's not needed. We all
I think we lost Krista for just a second. Give me just a second.